I'd like to appreciate your attendance, and we'll start with this one. Yes. So I'd like to start simply, inshallah, and as we go with the case, it will be more advanced. Starting with this interactive case, this is a 50 years old male with a known case of diabetes on insulin hypertensive, presented to the ER at around 5 a.m. with a history of chest pain. He started around 1 hour ago. And the pain is central, squeezing in nature. He gave an history of vomiting and profuse sweating. The patient is actually now in the triage, and he's waiting for the doctor, which is in between two brackets, the cardiologist, to assess him. The initial vitals is his blood pressure is 100/65, his heart rate is 95, and saturation is 94. So how would you approach this patient in the ER? And you are the first one who will be encountered with, apart from the nurse. So if anyone can give me any idea.
Okay, Assalamu alaikum.
Yeah.
Okay, my approach for this patient is starting from ordering the ECG within 10 minutes.
Okay. So you want to ask for an ECG within 10 minutes?
Yes.
That's the ECG.
Okay, this ECG shows sinus rhythm.
Okay. Anything else? Or what are you looking for?
For ST signal elevation, that's for stratify the patient for BCI. At that time, there is no acute ST segment elevation and there is no ST segment depression.
What else you will do?
Okay, I'm asking for troponin.
Okay, you will send for troponin, cardiac enzymes. What else?
Yes, and the vital, as you mentioned, the patient is vitally stable.
Yes, but I'm having severe chest pain, squeezing, and I'm still getting this chest pain. It's not going away. And
we starting full anti-ischemic medication, loading patient with aspirin, clopidogrel, and high dose of atorvastatin, and do bedside echo.
For that, what you would do?
Can I take history from the patient again for the nature of the pain to be sure it's a typical chest pain?
He cannot give you that full proper and history.
Because in pain.
Yes, he's in pain and he's getting this, and his vitals are kind of stable. This is the initial ECG. You're trying to get him some painkiller.
I will give him morphine to relieve the pain.
Will handle you in a morphine, and the patient is like getting a little bit well, but still, it's obviously he's looking ill. So the second thing that you need to do is what? If you're having a normal initial ECG, then the next thing is to do.
Repeat the ECG.
What? Sorry?
I can repeat the ECG again.
Yes, please.
Serum
so
troponin.
ECG after 10 minutes.
Yes.
If you send for cardiac enzymes, and I think that would need to take how much?
Cardiac enzyme, 0 to 1 hour. 1 hour it take.
Right. So the best thing to do is usually the message here is that if you have an initial ECG that is normal, and the symptoms is very convincing that this looks like an ACS or ischemic chest pain, then the best thing or that you should do is keep doing an ECG, repeating the ECG every 10 to 15 minutes, looking either for this ST elevation or for any hemodynamic changes in the ECG. So that would be supporting your diagnosis. So this is the second ECG that you ordered for, and can you read it?
Yes. This will show ST segment elevation in the lead 1 and inferior ST segment elevation more in the lead 2 than lead 3 with the reciprocal change in V1 extending to V3, V4 also included.
So I handed you this ECG and the nurse is beside you. What things What is your next order?
Okay. Is this an cable center for PCI?
Before that,
Before that, I have to do R6 and 7 and 8 ECG for posterior extension.
yes. So you want to do posterior ECG.
Yes, posterior ECG. Yes, it shows frankly ST segment elevation extending from the V7 to V9, going with posterior infarction.
Anything else you need to ask for?
Okay, I'm looking for.
The guy is still standing there and waiting for you. Do you want to ask him anything else? So you ask for the 12 lead ECG, the 15 lead ECG, and
I'm looking for the vital for regarding blood pressure and pulse. And
you did the posterior, you did the 12 lead. Anything else in the ECG you want to ask? You want to ask for
the right side V4
right side ECG? Yes, that's his right side ECG.
So Dr. Magdi, so
yes, there is ST segment elevation in the VR2, VR3, and extending till VR6.
The diagnosis
is extensive posterior MI.
Okay, what's next? That's inferior posterior MI with what? With RV involvements, huh?
Yes.
Then what do you want to ask? What is your action exactly?
Okay, I immediately loaded the patient with clopidogrel aspirin and atorvastatin 80 milligram and asking is this area for the BCI and looking for the time window now.
Okay. So if I told you that the nearest hospital is like around, I mean, while preparing the patient and getting the ambulance and everything, we will get him like in 1.5 hours.
Door to door or door to balloon? Sorry.
Okay. What are the options?
Okay. Yeah. Okay, this is an option. To give him aspirin 300 milligram, Plavix 600, heparin 500, admit to CCU, or to give an aspirin 300, Plavix 600, full antiplaze and send him for nearest BCI cable hospital, or to give him an aspirin 300, Tika 180, heparin half dose and antiplaze and send him to the nearest BCI cable hospital, or to give an aspirin 300, ticabrol 180, heparin and send him for the nearest BCI cable hospital. Okay, I will choose in this answer B.
B?
Yes.
Why?
Because this patient was transferred in 1.5 minutes, that is mean 90 minutes. So in out hospital BCI should be within 120 minutes. I think they received the patient at 90 minutes and the time from the BCI to balloon, it will take another 60 to 90 minutes. So the patient out of the window is better to give him a lysis. Am I right?
Any other ideas? Well,
okay, option C by exclusion is out.
I would like to give me each option why it is,
okay,
whether it is right or wrong. So if you said the first one, you will give him aspirin, the Plavix, the heparin, and you admit him to the CCU, I mean the same hospital CCU. Is this right or not? Do you do that?
No,
it's wrong. Hospital, let's say where? In any...
it's not an answer because the patient...
If I assumed he came to Ibrahim Malik Hospital and you didn't have any BCI, but I can transfer this patient to Markaz Al-Gam, for example, and this will not take more than, 90 minutes. From the first medical encounter to the table, on the table, he will be there. And I can guarantee that he will be in 90 minutes there, for example.
Okay, I will give him straightforward BCI.
You will what? You will do what? So the first one, is it right or not?
Not right.
Not right. So you will not admit him to your CCU. You will send him there.
Yes.
To the hospital. Number 2, طيب, who are giving aspirin, Plavix, heparin, full thrombolytics, and send him to this hospital. Here, Markaz Al-Gam. Do you do that?
Yes. Yes.
Would you do that? Like,
No need for lies.
Sorry? So let's
No,
go.
no.
Okay,
If
we'll go
it
to
is less
C.
than 1.5 hours, if it's less than 2 hours, no need for lies. I will send him directly after loading.
Okay.
Okay, we go to C answer.
The difference between مثلا B and C is that then I said full alteplase or half. Whatever.
No, there is no half dose of lysis anyway.
No, but the last one is a 300 plus
Anticabrogol 180 and then
for nearest BCI hospital.
here's the trick in the time, I think, between B and D for calculation of the time.
The issue timing that you know, the time frame that you know in general for any patient with ACS.
A patient transfer for a near area BCI, if it was done within 120 minutes, you can transfer the patient directly. If it's more, you start lysis for the patient, and then after the patient, within 24 hours, should be sent for the near BCI or immediately if there any mechanical complication.
Right. Let's agree on this. Time, by the way, time frame. This is a true. That's an ABCs. You have to know it by heart. Okay. The 120 minutes from the first medical encounter to the crossing the lesion or the wire, that's the time. If you can guarantee this, then you send the patient without giving any analytic therapy, okay? And they keep asking these questions.
Yes.
So you don't give alteplase. Now, what is the other questions that I will ask you? Do you know the difference between what we call a primary BCI, facilitated BCI, a rescue BCI, and a pharmacological BCI?
Yes, yes.
For facilitate.
Huh?
Okay.
The facilitated one, if the time will be more than 120 minutes, I will start full dose of alteplase and transfer the patient. This is the facilitated type.
Okay. Any other idea? Fine. The facilitated is the one I mean.
Facilitated, they do have dose of thrombolytic therapy, and then transfer the patient for PCI.
This is obsolete now. Okay. You know, you don't get. They used to give even those who can go for BCI, okay, for hospital within the time that you want. They used to study why not to give for them thrombolytics as well. Give them thrombolytics and send them to the hospital and get in a BCI. That's not actually increased mortality. The better thing is this is the facilitated. They don't do it anymore. Primary BCI is the one that we are talking about. You shift the patient directly to a catheter. Okay. Within your hospital, inside the hospital, the door to get a catheter has to be within 90 minutes. If you're going to transfer the patient, that is within 120 minutes. Okay. The rescue BCI is what?
Within 22 hours. If the patient failed to respond to lysis.
Yes.
Or develop mechanical complication or arrhythmia or instability.
These terms, you have to know it by heart. Timing, we said there is 90 minutes, there is a 120 minutes. How about thrombolytics? If I gave it after, when you cannot give a thrombolytics at all, even if the patients came to you, what is the time that?
12 hours.
12 hours, yes. Yeah. What else? You can still do BCI after 12 hours?
Yes.
After 24 hours. Okay.
Yes.
Right. Anyhow, so the right option here is D. Okay. One more thing, if you are going to plan to give a patient thrombolytics, what will be the suitable dual antiplatelet that will be given with thrombolytics?
Clopidogrel and aspirin.
Clopidogrel and aspirin. Can I give ticagrelor or prasugrel?
No. Only Plavix.
Or increase the risk of bleeding.
Right. So now your patient he was able to reach BCI Cable Hospital, and he went to the cath lab, and he received the initial treatment for all the who were dual antiplated, the heparin, and the PCI was done to the RCA. Okay, he's now stable, shifted back to the CCU in a stable condition. His blood pressure now is 115/80, heart rate is 51, he's satting 98 on room air. A repeated ECG was done in the CCU. That's his ECG. Once the patient comes to the CCU, the standard of care, the nurse will repeat the ECG for him. They will give you the new vital, and they will endorse each other all the other information. One of this is this ECG. So, and they called you. You were standing there in the CCU once the patient arrived, and they handled you with this one. What you will do, and what is it?
This is a 2-to-1 heart block as complication of the inferior MI.
Okay.
The heart rate scan mentioned 51.
That's Mobitz what? What do you have here? Mobitz 1 or 2?
This is Winkebach.
Wimbach 2.
Wimbach is 1 or 2?
Wimbach 2.
There are progression.
I have to be.
One strip in the bottom of the ECG.
Yes, in lead, it seems lead 2.
So what you will do? I give you this
Just
ECG.
observation.
Just observation in setting of the inferior MI with complete revascularization. I just monitor.
You were on the SHO with you to ask you why not to put him on a pacemaker.
Still there is chance he might return to sinus even up to 3 weeks.
Okay. Does the location of the MI?
Yes, definitely. It is, since it is an inferior, and there is an involvement of the RCA, and there is involvement of the conduction system, most probably it matters, yes.
So if it is an anterior, I mean, if it is an anterior MI, is there a chance of to get back? Or
I might think, no, I might
Yes,
think
if
really
it-
to,
Yes, there is a chance, but I think we will wait for 5 days.
The general rule, just the inferior MI usually, there's a high chance it will go back to normal, okay? But usually the anterior, if you do develop any kind of block, most probably it will be a permanent, but of course it works both ways. So anyhow, if the patient, the most important thing here is that you need to ask about the vitals. If the blood pressure is fine and the patient is stable, then you will observe him at any point. If the patient, his blood pressure dropped or he's having any symptoms, then you will put him as a backup. You can sometimes use a backup, if it is complete heart block, for example, you will put him in a backup pacemaker, okay? Until it's resolved out, and you will see later. But this
sorry,
night,
sir.
at night,
Sorry, sir.
Yes,
Just a little clarification, if you don't mind. If it is anterior and the vital signs, it is deteriorating, and the patient, it was really symptomatic in regard to the heart block. Do I have to really just make a temporary pacemaker, you mean, and then observe him, or just go for a permanent pacemaker, or what it is, if you don't mind?
Okay, I think this may need an EP. Like in general rule, they will observe the patient usually when they getting. As I said, anterior is more probably it will be a permanent, but that doesn't mean that you will rush and put a permanent pacemaker directly.
Okay, thank you.
Right. Then at the night, the nurse called you regarding the same patient, and she was concerned about increasing the requirement of the oxygen. When you were sleeping and the patient, the nurse called you and she told you that he was fine. And then I start noticing that he's decent, nasal cannula. If you can come and assess him, please. So while you are heading toward the CCU, what are the possibilities that you will bear in your mind?
Okay, regarding mechanical complication of MI, especially MR in setting of the inferior MI.
Number 2.
VSR, ventricoseptal rupture, and cardiac tamponade. اللي هي 3 wall rupture complicated by cardiac tamponade.
Now, upon arrival, you found him lying 45 degrees. He was in face mask, 6 liters, expired distress, blood pressure is 100 over 50, heart is around 70. His chest, they're showing a bilateral injury with rails bilateral. Every volume overload, and there is his first and second heart sounds were audible, and there's no added murmurs. You couldn't appreciate any murmur actually. So what would you do? What is the diagnosis?
Going without murmur, my diagnosis mechanical complication in form of mitral valve disease.
And what is
severe MR?
What you will do next?
Okay, bedside echo immediately.
Okay. So that was his echo.
There is a rupture papillary muscle.
Okay. So
There is posterior rupture papillary muscle.
Right. Now, so the message here is that you need to do always. The patients after UCI, he went to the CCU. You always keep in mind that he might develop any kind of complication that will happen in a few hours to the first initial 5 to 7 days. And whenever you have any suspicion, always grab the echo probe and assess for the patient. But the difference between why you said this is a not by clinical examination, not what the other possibilities. You're thinking of VSD or VSR.
VSR, there is a harsh murmur, continuous murmur. In the MR, there is absence of the murmur because of rapid equalization.
Okay, perfect, excellent. Right. So this is the message here. Actually, this is a real patient, and unfortunately, they called for her resident at that time, and he came at the night, and he thought that giving a shot of Lasix will solve the problem, and slept over it. By the end of the morning, she was already on intubated and sent to the emergency
surgery.
Yes. We didn't make it. Fine. This is just a general review regarding the ventricular septal rupture, free wall rupture, and acute MI. You have to keep it all in mind. And these are the difference. All of them happens in the same time variation, which is 3 to 5 days. In the VSD, you will have a murmur most 90% of the time. In the acute MR, it's like 50-50 you may find or not. So if you really find it, doesn't mean that there is no acute MR. And then you need to do, of course, the echo is the most important thing. If you're still thinking of it and your transthoracic is normal, then you may even go for TE to search for it. Right, case number 2, this is a 53-year-old woman who presented to the emergency room with substernal chest pain radiating to the left chest and neck following an hour of long exercise session. And the patient had history of dyslipidemia, hypertension, and she had history of anterior stimuli 2.5 years, almost 3 years ago. And at the time of at that time, LAD was stented with a bare metal stent. In the ER, the patient's pain was associated with diaphoresis and dyspnea, but a negative troponin, and the symptoms resolved right 15 minutes after arrival. The patient was admitted for cardiac cath, and this is the ECG. Anything you can appreciate here?
It is sinus rhythm ECG with feature of old anterior MI.
Okay. This is the patient went to the cath. That's the
This poor R-wave progression.
anyone. What's your diagnosis here? Anyone?
Okay. There is distal stenosis. First, I have to look for the stent, but the image is not that clear.
Anything very obvious in this one? Can you appreciate
إيه لا
it?
بس ده مظاهر
Can you name the arteries type if you see it here? What is, I will show you, this is engaging which system, by the way? This one.
The left system, left main and the LID and the
Left main.
left chap. Yes.
Left main giving what? Usually. Left main will give you what? LID and SEC, right?
left anterior.
Right?
Anomalous RCA.
Yes. Where is
Yes.
it? Can you see this one?
Yes. This is the RCA. Originate from the left side.
From
Anomalous RCA.
Yes. This is anomalous RCA coming from the LAD, the first part of the LAD, okay? So you can say that, see here, there is lesion in the LAD, stenosis, and there is an RCA coming out from this part of the
left.
Right. So the cath view is showing anomalous RCA taking off from the first septal branch of the LAD, anomalous RCA taking off from the proximal LAD, anomalous RCA taking off from the left main, or anomalous RCA taking off from the proximal LAD with the high-grade lesions in the LAD itself.
What is D?
D, right?
Yes.
Right. Anyhow, the patient went there. They repeated for him an echo, and it found like it was the same. And because of the technical problem and the in-center stenosis, they thought of CABG would be the solution. They did for him the limiter LAD. Now, the message I want to discuss it here is the congenital anomalies. What do you know about congenital anomalies regarding the coronary arteries? Anything?
What are the types of congenital anomalies? Congenital RCA from the left coronary cusp, congenital left from the right, or from non-coronary cusp, or Alcaba or Arcaba.
This is, what do you mean by Alcaba?
Anomalous left coronary from the pulmonary artery.
From the pulmonary artery. And how do they present usually?
Sudden death or early sudden death or early ischemia in the childhood age.
What is the solution for it? Usually.
2 months.
Is to solution or
What is the treatment for it?
Treatment is to re-implant the coronaries in the aorta.
Surgery, right? Okay.
Bypass.
Yes.
That's again, Alcaba. Usually they will have a large RCA.
Re-implantation is difficult because the variable arteries.
So anomalous of the left coronary artery from the pulmonary artery, presented usually at 2 to 3 months of age, will lead to ischemia, and definitely the treatment is
Surgical.
the most important thing is that you can divide the anomalous from the same side, okay, from the same sinus, usually which is benign. And you can find like the separate corners from the RCA on the right side, or separate circ and LAD on the left side. That's normal. Anomalous from the opposite sinus. That means you have someone getting, one of the arteries getting from the opposite sinus, like left main coming from the right, or the RCA coming from the left. The more common is the RCA coming from the left sinus, or the circ coming from the right sinus. Now, your approach usually, the message that I want to deliver is that if you have any coronary anomalies, you have to put in mind the first thing is the course of this artery, if it is malignant or benign, and then if it is, what do you mean by malignant and benign? Have you heard of this before?
Okay, the malignant course either intra-arterial between the pulmonary artery and the aorta, or deeply angulated in this course, or retro-aortic.
Which one of these images is the benign? Which one of them is malignant?
The intra-arterial last one, it is malignant.
The first one, the picture of the above is malignant, or the one in the bottom?
No?
And this is usually, it comes as a CT, diagram, but this is it kind of schematic diagram for a CT, for example. The one is the pulmonary valve, which is usually the tier, and the aorta is a little posterior. And yes. Which one again is it? Which one is
the last one, intra-arterial, it is a malignant.
Yes, I mean the one in the bottom. See, when you the one above is going around, wrapping around the pulmonary or behind. Oh yes, or behind. You can see the left main coming from the right cusp. It's going all the way in front of the pulmonary and going
from outside. Yeah,
oh, that's fine. Or the one like coming from behind the retroaortic actually, and if it is in intra-arterial, that is the one which is malignant. The message is, if you have this, the first thing you need to think in your mind is if it is if you've done a cath and there is a coronary anomalies, they can't still know in the cath the course, but the best thing is to do a CT to look for this the course of the coronaries. And if it is benign or malignant, if it is malignant, then you have to do a surgery, of course. If it is a benign one, what do you do next? Usually
look for inducible ischemia.
So you need to look for the evidence of ischemia. You have to do functional and image-wise. If there is any evidence of ischemia, then the thing is you go for surgery. If there is no evidence of ischemia, then
surgical intervention. Follow up.
Yes. Case number 3, this is a 6-year-old woman, history of dyslipidemia, presented with a history of chest pain in the emergency department, and the patient had a systolic blood pressure of 90, heart rate of 100, and troponin was positive. This is her ECG. What can you observe here? Anyone?
I took my chance. I will let the others to participate.
Is there an ST elevation here? Can I appreciate?
Yes, there is biphasic T wave in V4, V5, V6. Even V2 and V3.
Yeah, you can appreciate that there is an ST elevation. Okay, anterior leads within.
And the AVL is so clear in the AVL and lead 1.
So they took patient to the cath lab, and this is her. You see, this is for the right system, right? And this is for the left system. They brought you these kind of images, what you would think. Patient is having anterior lateral, for example, and this is chest pain, or a cath lab, they put for her cath. This is the any lesion you can appreciate here.
No, we can't appreciate any lesion.
You can pass it as a normal coronaries, huh?
Yes.
So they did, since they're already doing the coronaries, they did for her. What is this?
This is Takotsubo.
LV ventriculogram.
This is the angiogram, right? The picture in the LV and the contrast. Then showing what you said.
Takotsubo apical ballooning.
So obviously the base, you can see here the apical ballooning and the hyperkinetic, the base of the heart, and this goes with Takotsubo.
Takotsubo myopathy.
So following angiography, the patient was admitted to the coronary care unit. Echocardiogram showed a ejection fraction of 35 to 40 with akinetic dyskinetic apex, consistent with the diagnosis of Takotsubo cardiomyopathy. Now, case number 4. This is a 60-year-old man, history of COPD, who presented to the emergency room, intermittent chest pain for 12 hours. The ambulance technician found the patient to be diaphoretic, short of breath. In the emergency room, the patient had chest pain and is hypotensive, and that his troponin is positive. CK is positive as well. This is the ECG, that you can appreciate here.
Inferior the elevation.
Elevation in the inferior leads, right?
Yeah.
That's minus, right?
Mm.
Right. This is the repeated ECG for him. What you can appreciate here?
It is an inferior elevation with heart block. I think it is a
Complete
heart
heart
block.
There is right bundle branch block actually. So if you see
Yes.
in the view, right, you can marshal. Okay. This is a complete heart block with the right bundle branch block. They took him, the patient, underwent emergency coronary angiography. On arrival in the cardiac cath, the patient was alert but hypotensive. They put for him a triple lumen catheter, the right femoral vein, and the patient was treated with atropine and epinephrine. And this is his cath, the right side cath. What do you appreciate here?
Total occluded RCA. Proximal.
Okay. How about
Total
this?
occluded proximal RCA.
Okay, what is this one?
Small diffuse disease to the left system.
This disease of the left system, both RCA as the CERC and the LAD. You can notice that the size of the vessel itself, and if you compare it to the size of the diameter of the catheter, it's smaller, so diffuse, but there's no clear disease type. Now, the RCA was wired, but despite a multiple balloon inflation and use of the thrombectomy catheter, the artery couldn't be opened. Now, how about this one? Name the structures that you can see here. Apparently, there is so many wires inside.
Big tail catheter.
Number 1, okay. This is the big tail catheter, okay. Then
The lead pacemaker lead.
are you sure this is pacemaker?
No, it's an intra-aortic balloon pump.
Where is the inter? This is the one, right? The one you can see inflating.
Yeah.
This one.
Deflated, yes.
This is intra-aortic balloon pump. This is the big tail catheter, and that's actually swan guns, okay? Going to the left valvular.
Okay.
Right. What is the... Now they are injecting contrast. What you can appreciate as anomalies or pathologies here. The patient having an MI, and he is hypotensive and on the table, and this is when they are injecting. Are you appreciating anything here?
The contrast is deviated to precardial.
No, more than going to the
Precordium. This free wall rupture.
How about this one? I think looking more clear. Going where actually? Who are injecting it here? They're going like this. Now, this with this one. What is the structure?
RV.
RV. So from the LV to the RV and even extending back to the RA.
The RV.
What is this?
VSR.
Yes. Okay.
VSR.
So the patient was intubated in the cardiac cath lab. An echocardiogram showed a very infarct non-restrictive apical VSD with a left to right shunt, akinetic RV. The ejection fraction was estimated by 40 to 50% with inferior posterior akinesia. The patient was taken emergency to the waiting room for a repair of the VSD. The VSD measured approximately 2 centimeters. It was closed with a patch of inferior pericardium. Intraoperatively, the RV was noted to be akinetic. Was declared dead. Right. VSD usually, if it's discovered at night or whatever, the answer always is you have to take emergency surgery, okay? And usually the is very high, and even with the surgery can reach 50%. Right. This is the last question.
Sir Magdi, معلش, your voice is fainting.
Okay. How about this?
We can't hear you enough, Dr. Magdi.
How about now?
It's distant the sound, yeah, Magdi. I think can I check with the mic again?
صوت مروحة أو حاجة.
The same like you have to put another mic. Okay, the same?
I think it's better
No,
now.
not clear.
Huh? Clear?
Yeah.
Right. Okay. So let's move this one. The patient is 56 years old. He's a man, history of hypertension, who had stopped taking his antihypertensive medication for the last 7 weeks. By the time he arrived to the ER, he was having continuous severe substantial chest pain. His blood pressure is 110, heart rate is 91, and saturation is 96. You order an ECG, and that is, can you read it? Anyone?
Okay. So it's right with the branch morphology.
Sinus with right ventral branch morphology, and the patient having chest pain. What do you do?
Yes. If it is new RBB with chest pain, I will leave the STEM equivalent. I will take him to cath lab if it's available.
Okay. How about left bundle?
Left bundle, I have to do a modified Scarboza criteria.
But again, if you have a new right bundle or a new left bundle, both of them equally that to STEM equivalent.
Yeah.
The patient was sent to the cath lab according to the accordingly as an ACS while receiving an intravenous nitroglycerin, and that is his. Can you read this? This is an ephemeral approach, right? Engaging the left system.
Okay. Left main looks normal.
Left main.
There is an ostial LID.
Is foreshortened, and then and that is what? What is this one?
LID. Yeah.
This LID? That is the stack, right? That is
Okay.
the M. Anything you can appreciate here?
I think there is an ostial of supraximal lesion.
Thing that more obvious or common when it comes to the exam usually.
The dissection.
Where is this? Can you check this one?
Yes.
The dye hanging
Yes.
here?
Dissection, yeah.
Right? In the OM. First OM, right?
First wave view.
It's another one. This is another view, the spider view here. You can see. This is the left main. Okay, here the third, and how we can you appreciate this one? See? Is it clear?
Yes.
for you?
Clear here. Yes.
How about this one as well? You can see it's very clear here, right? The flap is there. Okay. And then,
Right. Yeah.
yes. Now, because of the patient's ongoing chest pain, we concern that is the dissection would propagate into the left main coronary. The circumflex was stented. Okay. You can see it here.
Stallone.
But what is this one?
Also, there is a dissection before the wave.
But it is now propagating where? You know, that is very clear one. Which one? This one? This is the cell. So proximal cell. Actually, there is propagation of the.
Yes.
There is the flap. So this one is very. What do you call this?
Dissection above to
What is this pathology usually? Oh,
spontaneous coronary artery dissection.
it's scat. Yes. Usually they keep it.
Spontaneous.
Evidence of the ongoing ischemia and the chance that it will propagate, they usually stand type. How about what is this one? For the same patient, they did this. What is this?
Injection to pulmonary artery.
This is the pulmonary. Renal, right?
Pulmonary, yeah, yes, I'm sorry.
Okay, for the right and the left renal artery, looking either for both, and because of the patient was very hypertensive, they were looking for either stenosis or evidence of fibrovascular dysplasia or any dissection. They just do that. Some of the old school, I think they still do the angiogram for the renal. So during this case, the patient had persistent chest pain, elevated blood pressure, systolic blood pressure was close to 200, and they started on a multiple medication, like for lowering his blood pressure, and they were visualizing his renal arteries for any stenosis. So the final diagnosis message here is that this case of spontaneous coronary artery dissection in the setting of hypertensive. Okay. So I think this was the last case, and that's it, I think, for this.
Thank you so much, Magdi. Just the last case, it was a spontaneous coronary dissection.
Yes.
Okay, so remember, a spontaneous coronary dissection, the most common association with is the fibromuscular dysplasia. Okay, that's why sometimes they do renal angiogram just to make sure how things are. So remember this one, okay? Spontaneous dissection, fibromuscular dysplasia. Okay, I think thank you so much, Magdi. Thank you, all of you.